Добрий вечір всім. Добрий вечір, Пітер. Зараз будемо починати. Пітер, покажіть, будь ласка, чи ви чуєте мене через перекладачів? Добре. Дуже дякуємо всім, хто до нас приєднався зараз. І нагадую вам, що ми знаходимося на серії вебінарів, яку ми проводимо разом з Центром Кабінету міністрів, Координаційним центром Кабінету міністрів України у партнерстві з ЮНІСЕФ, з Міністерством охорони здоров'я, з Національною службою здоров'я України. І це наш проєкт про спеціалізовані послуги для дітей та підлітків у сфері ментального здоров'я. Ми реалізуємо цей проєкт у межах всеукраїнської програми ментального здоров'я «ТИЯК» за ініціативою пані Олени Зеленської. І ми створили цей проєкт з Європейським товариством дитячої та підліткової психіатрії ЕСКАП та доктором Йоргом Фегертом. Професора Фегерта сьогодні не буде на цьому ефірі, також як і пані Оксани. Так сталося, бо вони зазвичай є. Тому нашого сьогоднішнього спікера я буду представляти сама, але спочатку я перевірю, чи в нас всі доєднались до Zoom. Я не бачу цього в себе в чатику, тому операторська команда щось мені скажіть, чи люди зайшли на Zoom, чи ні. Ага, зайшли, мені показують, що зайшли. Добре. І тоді я представляю нашого сьогоднішнього спікера. Ми, як завжди, спочатку слухаємо спікера, а потім задаєте ви питання. Тобто ви можете присилати питання паралельно в чатик, і наприкінці я буду задавати їх професору Пітеру Hoekstra. І ми будемо слухати відповіді всі одразу в кінці. І так, наш сьогоднішній спікер – це професор Пітер Hoekstra, завідувач кафедри дитячої та підліткової психіатрії Гронінгенського університету, директор Accare Child Study Center в Нідерландах. І наша сьогоднішня тема – це тикозні розлади, сучасні дані про етіологію та лікування. Професор Пітер Hoekstra – дитячий та підлітковий психіатр у спеціалізованій амбулаторії в Гронінгені, де працює з тиковими розладами та РДУХ. Він досліджує ефективність фармакологічних та психосоціальних втручань при РДУХ та супутніх розладах, а також вивчає етіологію синдрому Турета і РДУХ. І я прошу пана Пітера з його презентацією розпочинати.
Yeah, thank you very much. First of all, I want to thank really the organizers. It's a big honor for me to be able to speak for colleagues from Ukraine. And I think it is a great project to invest, especially also in mental health for children within the country. And I'm also very glad that the topic of tic disorders, tonight's topic, is also on the program. So we're talking about tic disorders. The most prominent example, or it's most best known by the name of Tourette syndrome. Tourette was, Georges de la Tourette was a French neurologist who lived and worked in the 19th century, and whose name has been given to the syndrome, which is now part of both ICD, the International Classification of Disease, and DSM, the American classification system of mental disorders. And really, the defining feature, there's a group of tic disorders, but really the defining feature are so-called tics. And this is how a tic is being defined. It's a sudden, rapid, recurrent, non-rhythmic, either motor movement or vocalization. So there's two types of tics, motor and vocal tics. So motor tics is things that you do not hear, but involves all kinds of movements in the body. And it also makes sense to distinguish between two types of tics, either simple tics, the name suggests it's just one muscle that moves, and complex tics, which involves a bigger a group of muscles. Now, we will come into detail. One thing So tic disorders are nicely at the border between neurology and psychiatry, because unlike a thing like epilepsy, which just happens to you, or other movement disorders as known within neurology, tics are actually, for many affected people, suppressible. So it's not something that is totally independent from the will. The fact that they happen are, but people are mostly able to suppress them. So we already said we have motor and vocal tics, and both can be subdivided into simple or complex tics. So the first type of tics are the simple motor tics, and which are also the most frequent tics. So by far, the best known or most prevalent tics is just just happening in the face. Excessive eye blinking, nose movements, head shaking, shoulder jerking. So they are sudden, brief, apparently meaningless, and they tend to happen in so-called bouts, so in groups of, and when you have an eye for it, you can readily see it in daily life, or sometimes even in television, that you say, well, this person apparently has tics, and they do not necessarily have to bother people. Oftentimes they can be mild. These motor tics can also be more complex, meaning it involves more than one muscle group, sometimes things lasting longer. And here, those more complex movements can blur into what you can call parts of normal behavior, things like touching things, but also a certain gesture, sometimes obscene, or complex movements involving both some grimacing in the face, but also at the same time combined with bodily movements, head shaking. Yeah, so it almost looks like a repertoire of movements that can be quick, that might appear as a purposeful movement that really serves no purpose. Now we turn into the vocal tics, so things that involve sounds, and here the and the more simple tics are just things like coughing, throat clearing, sniffing, whistling, brief sounds, so no words, animal noises that people from time to time may do. Finally, we turn into the more complex vocal tics that involves whole words, sentences, sometimes repeating certain things, but also things like shouting out whole sentences that do not really make sense. One thing about tics is that there can be a really large repertoire of different tics. This has also been studied in a factor analysis, and Danielle Katz tried to subdivide people with tics, because no one is really the same, into either a group that was mostly characterized as having so-called socially inappropriate tics, sometimes obscene language or rude or obscene gestures, and another with more focus on body tics, certain movement just within the body, and there's a group where really the tics are more present within the head and necks. And I think that the latter one, the factor 3, is actually the more typical feature that you do see. Tics are not, people with a tic disorder do not necessarily have tics all the time. So there may be times that they are not there, and they are not just randomly there. They tend to occur in so-called clusters, and these clusters are present whether you look at it at a smaller time scale, like within minutes or hours, but also they cluster also certain days with many tics, as opposed to other days where there's hardly any tics, and the same applies to the whole pattern within the year in terms of weeks, months, or even years. So this graph is trying to summarize this. So the vertical lines are just ticks, and you see they cluster together as so-called bouts of ticks. And there may within certain days be bouts of ticks, and it goes on bouts of ticks when you look, and so on when you look at a wider time scale. It's just an illustration of the point of the previous slide. How do ticks typically develop? It is quite typical that ticks almost always start in the face, so in the upper part of the body, and over time they tend to also involve the more distant part of the body, such as the legs. Also quite typical is that ticks start in an affected child as simple ticks, and over time more complex ticks may appear. And finally, what is also quite typical is that motor tics is often the starting tics, and only over time you may also see focal tics. So tics really start in children, and the typical age of when children show their first tics is around 6 to 8 years. And hardly after 10 to 12, there's hardly any new onset of tics. So it really has an onset in childhood. So let's have a look about the typical clinical course of tics. We have done a study within children whose siblings had tics, so tics are familial, and some of them developed tics, and we saw that hyperactivity, so even when the tics are not yet present, most of these kids are already more hyperactive than the typical children without tics. Then I already said it mostly starts around the face, and this is typically around the age of 6 to 7. Tics may start around the head and neck age, and then 1 or 2 years later, focal tics may appear. And again, somewhat later, OC stands for obsessive compulsive symptoms. So so it's more about urges or things that are people, that kids feel forced to do, some repetitive behaviors, and then and that is also around the age when the tics are mostly at their most severe. And not always, but quite typical, you see then a decrease in adolescence, and only about 1/3 continue to have tics in adulthood. Well, this says 50 to 60%, but I think 1/3 is the more correct estimate. So this is about the same that I just told you, but illustrated more graphically. So already at a young age, children who are about to develop tics are more overactive, perhaps more demanding as a toddler, and then then around 6 years you get motor tics, then focal tics, and then you get obsessive compulsive behavior, and you see that those obsessive compulsions often increase, whereas the tics decrease. So this is a more graphical, but it is a lot conditional on environmental factors. Let's have a close look at some of the important hallmarks or characteristics of tics. I already briefly mentioned that tics are often suppressible, and one really interesting feature is that tics don't happen out of the blue, but are preceded by so-called urges. We call them premonitory urges. So people often compare it to some itching. So people feel that a tic has to come out. And this is often, so they don't just happen, but people feel them coming and may then suppress them, at least temporarily. What is also quite typical of tics is how context dependent they are. So sometimes when people are alone and just in a quiet environment, the tics may really ease and go away, whereas in other environments, tics may be much more prevalent, and also tics may be almost contagious. One good example is we sometimes have a Tourette's Patients Association, an association of patients with tic disorders, where they all come together at an annual meeting, and then some people really see other persons having tics there, and they have a tendency to also take over those tics. Also quite well known is that tics are highly variable over time. We already talked about these bouts of tics, but also at an individual basis. So there is a big variety of tics, but one certain type of tics may be present for a while, but then goes away and maybe over time replaced by some other tics. So also the type of tics are not stable for one person, but is really variable over time. I already mentioned the so-called premonitory urges, but these urges are really part of a wider range of so-called sensory phenomena. So people with tics are really known to be more sensitive, sometimes to bodily sensations, but also to they also tend to show so-called echo phenomena. So they sometimes feel an urge to mirror what has just been done, and also so-called Cropper phenomena. Obscene gestures are also sometimes present, but also other types of what you could call socially inappropriate behaviors. One example is, imagine you are about to see a theater show. People initially talk a bit while the show has yet to begin, but then the show starts, and really at that very moment when the audience is becoming quiet, then suddenly a shouting may take place. So which is of course socially inappropriate in that context, but the urge of doing that is quite apparent. And also there may be heightened senses of symmetry. Sometimes you have those shops, so people may also feel a sense of left and right symmetry. Sometimes you have a shop which is really a one-way shop, because the shop wants you to see all items that are on sale. So you have to go through the whole way and then exit at a different place. For some people that doesn't feel right. They don't think it's balanced, so they have the urge to go backwards and leave the shop in that way. So those are some of the things that not every people with tics has, but which are quite well known to be associated with tics. So a little bit more about these premonitory urges. How are they described? It's often described as some kind of sensory discomfort associated with the muscles, or some kind of tension, pressure, almost an itch. And whenever you then do the tic, then it feels as a relief. I already briefly mentioned Tourette syndrome as the most well-known and tic disorder, the classic tic disorder. So the criteria state when may there be Tourette syndrome, when there's multiple motor and at least one focal tic. So it's really a combination of motor and focal tics, many times a day, and at least more than 1 year, and with an onset before 18. One interesting thing is almost all psychiatric disorders within the DSM, the American classification system, they ask that there should be that there should be some kind of impairment associated with the mental problem. But within Tourette syndrome, that is not the case, and it's really a unique case within the list of psychiatric disorders. Here are just some diagnostic, if you wish, caveats. So it's good to know that sometimes patients or parents may totally not be aware of the tics. So then you may see tics that people themselves do not know. But also the waxing and waning pattern. So there may be at one time no tics, but it doesn't say that there are no tics. We already talked quite a lot that tics are suppressible, but it also means that, for example, in the context of a doctor's or clinician's visits, you may not see tics, but it doesn't necessarily say that there are no tics, given that tics, especially at such more formal appointments, may be suppressible. Also good to know, Tourette syndrome was once considered a quite exotic, perhaps even rare disorder, but it is not. It is actually quite prevalent in more than 1% of children, and it is perhaps best known for shouting out obscene words, so-called coprolalia, but that is only present in a small minority of patients. So so that is not a requirement. I already briefly mentioned the prevalence. About 1% of children fulfill criteria for Tourette syndrome. That means they have both motor and vocal tics. And these are present at least for a year. So it's a combination of several tics plus a persistence in terms of time. The prevalence of many children, up to 5 to 8% of children at school age, do have tics at some time, but more often than not, they're just mild, temporary, go away, and are just there for a short while. And but it's still thought that they form part of the so-called spectrum of tics. Tics are much more prevalent in boys than in girls, about 3 times as prevalent, and typically kids with tics do not only have tics, but also have other disorders. About half of them have co-occurring attention deficit hyperactivity disorder. We already saw that it is quite typical that hyperactivity may even be present before the onset of tics. About 1/3 has what we call obsessive compulsive disorder, and there may also a link with autism spectrum disorder. Let's move to the causes. It has long been known that Tourette syndrome, tic disorders are actually quite genetic. So genetic factors played a major role. So this has stimulated a hunt for the genes that may be associated with Tourette syndrome. And we can briefly review some of the findings or the lack thereof, using different techniques of trying to find tics. So one topic that I would like to talk about are the so-called genome-wide association studies, looking at so-called single nucleotide polymorphisms, or SNPs. But there's also been work that looked at more rare variants, either investigating so-called multiplex pedigrees, or looking at new mutations within so-called simplex triad, meaning the kid has the disorder but not the parent. So there must be some new genetic variant ongoing. First, back to the basics. How do we actually know that tics are genetically based? It all starts when you look at large-scale family studies, where you really see an increased risk in family members of affected individuals. So this is just saying if there's one with tics, then there's higher chances that within the broader family there's also other members who have tics. And another way finding that that genetic factors are involved is when you compare two types of twins, monozygotic twins and dizygotic twins. And monozygotic twins are genetically mostly identical, perhaps not 100%, but that's a bit a concept. And then you see that there's a larger concordance of tics in monozygotic twins that points to a genetic cause, but then you still do not have the genes. This is an example of one of the classic older twin studies, where we see that when there's monozygotic twins, when one has tics, then 77% of the cases, the co-twin also has tics, and this percentage is lower within the other type of twins, the dizygotic twins. When we look at, I will briefly review two types of studies. One is, I already mentioned it, the genome-wide association studies, or so-called GWAS studies, which is actually a hypothesis-free approach. So you don't say this and this, but you look at the whole genome, and you look typically at 600,000 to 800,000 gene variants at once. And the whole concept is that we all share so-called common differences in genetic factors, and it's just not one gene, but the combination of genes. So certain of these SNPs may be associated with Tourette syndrome. There's now one newest GWAS study in the making, but this is the most recently actually published this year. And then we see that this green dot is actually one genetic factor, and it's at chromosome 10, if I'm not mistaken, that is associated with Tourette's syndrome. So actually the first SNPs are being identified. But one of the issues with GWAS studies that you really need extremely large sample sizes, and what has so far been found is only able to explain a small proportion of the heritability of perhaps about 3%. And I already said it focuses on common variants as present in the general population, but it may just be one part of the genetic puzzle. So this is a slide that the more you increase the sample size, so sometimes up to 40,000, the more genetic variants you are likely to find. And Tourette syndrome really, unfortunately, lags behind in terms of sample sizes. So far, the biggest study is only about 10,000 cases as part of those genetic studies. So it needs a lot of collaboration across the world to increase the necessary sample size. But then again, common variants typically explain only a minority of the heritability associated with Tourette's. And there's also an alternative assumption that looks at not at common variants within the general population, but at so-called rare variants. And and here there's also been, I would like to illustrate two examples that illustrate the potential of so-called rare variants and and perhaps genetic heterogeneity. One study where a gene had been identified in a pedigree, a large extended family with several people affected who appear to share a variant that was associated with how the disease was running within that multiply affected pedigree. And also, I already briefly mentioned that studies that looked into children with tics where their parents did not have tics, so there may be a small mistake, a new variant that was not present yet, and that may be another way of finding genes. So this is a classic study of a few years ago, where just within one family, an histaminergic gene was being found. So this was a family of 2 parents and a total of 10 children in total, and many of them who were associated with who had tics, and where this histamine gene was really associated with the presence of tics within that family. So all in that family had that one gene, and it doesn't mean that every person worldwide has that gene, but within certain families, certain genes may be present and give a clue for the genetic background of the tics. And this is another paper where not using large pedigrees, but case of kids without children, cases of parents without tics, but the child has the tics, and then in up to 12% of those cases, new mutations have been found. And in this paper, there were actually 4 Tourette genes, but there should be approximately 400. And this is the largest. This is a preprint of this year that has not yet been peer-reviewed, but where using the same technique, 36 risk genes for OCD and chronic tic disorders have been identified. So to summarize, so there was a time that people thought, okay, Tourette's is genetically based, so there must be one major gene, but that was a far too simple concept. We can also say Tourette's is genetically based, but not necessarily always being inherited from the parents. It may also be genetic variants that have newly occurred. That is the so-called de novo variants. And it's also good to know that there may be, that there are likely many different, most of them that have not been a detected genetic pathway leading to Tourette's. So one could also say there may be many different genes involved that may differ from one family to the other. So perhaps it's also too simple to say, well, Tourette's syndrome perhaps is not one disorder. It also means that so far we cannot do any useful genetic testing within clinical practice. So this is more of a scientific background. But of course, it's tempting to see whether genetic heterogeneity also reflects the clinical heterogeneity. So that we discussed. So perhaps it is too simple to put them all together into one group, but perhaps we should be more careful of how to distinguish more homogeneous subgroups. Of course, it's not only genes that matter. We already saw that the concordance rates, even within monozygotic twin pairs, are not 100%. And there have been a number of non-genetic factors associated with Tourette syndrome, psychosocial stress. There's been some studies into infections, and there's also been work directed at unfavorable pregnancy or delivery factors. So they also increase the risk of getting a child with Tourette syndrome, probably in association with a genetic vulnerability. Before I move to treatment, I want to spend a few words about so-called PENDES. And PENDES stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infection. That has been quite an attractive, but also at the same time controversial topic. So it's about the topic, if there is at least a subgroup of people where tics or Tourette syndrome or obsessive compulsive disorder may have a link with autoimmunity and triggered or exacerbated through infections. That's the whole concept. So this is where the acronym stands for, but there have also been different PTANs or different names that do not necessarily link have a link with streptococcal infections, but also with a broader type of infections. So these PENDES criteria have been proposed, and that require that really describe a subgroup of children that out of the blue show a dramatic, often from one day to the other, emergence of quite severe obsessive compulsive disorders and or tics, or have an exacerbation, and where there's indication that they may be temporarily associated with group A streptococcal infections. So it's really centered about an old model, Sydenham's Korea, where there's antibodies are thought to not only respond to the bacteria, but also due to so-called molecular mimicry, meaning that parts of the body resemble parts of the bacteria, and also meaning that subsequent infections could lead to symptom exacerbations. So where do we stand with this concept? I already said that it's quite controversial. I think we have to say that there's no direct evidence, only some evidence. There have been some studies using animal models, but it's really not conclusive. And there are some, what you could at best say, so-called circumstantial evidence. So there have been some reports that there may indeed be an association of tics with infections, or perhaps with allergy, or with other autoimmune diseases running in the family. And there have also been some treatment studies that may suggest a therapeutic effect of immune-based treatments, such as plasma exchange, antibiotic, intravenous immune globulins, and the like. So this is a study that showed that mothers with an autoimmune disease history had a bigger chance of having tics in their, or Tourette syndrome in their offspring. And there's also been a number of old treatment studies where there was a higher presence of anti-streptococcal antibodies. So there have been some studies suggesting there may be a link, but there have also been quite some negative studies. So people who really looked at whether streptococcal infections are associated with with tick exacerbations, and we actually a few years ago did a study funded by the European Union and really found no evidence that streptococcal infections are associated with the onset of tics. So there was really none, but also not with tick exacerbations. Yeah, so I have to say I highly doubt the whole concept of PENDAS. I think it's not a very valid concept, although there are many dedicated outpatient clinics who think otherwise. So I think in this regard, there are really many unsolved questions. Is there really how many children should then have within the Tourette syndrome spectrum should then have this PENDAS concept? How do we actually define abrupt or acute symptom onset? And if there is supposed to be an association with a streptococcal infection, how should then be the temporal time frame? Yeah, so I think it's more open-ended than a solid concept. Let's move to treatment. So let's for now not focus any longer on these possibly infection-associated cases, but move back to Tourette syndrome and tics in general. So I want to close this lecture with spending some words about the treatment options that we do have. I think it's really it's really three types of treatment. I think the first, that may sound perhaps a little bit obvious, but I think so-called psychoeducation, so discuss what is going on with the family, and that is not necessarily bad behavior or a naughty boy that does things that parents or schools do not like them to see, but explain the background. Also discuss why at some points there may be tics and at other points there may not be tics, that doesn't necessarily reflect naughty or bad behavior, but that it is part of the disorder. So that often helps families to better cope with tics, and more often than not, you can leave it at that, and many families are fine. The second type of treatment is behavioral therapy. So there's really nice behavior treatments that use what is called so-called habit reversal. So you try to reverse the tics. So you do a different movement that is not compatible with the tics. We will come back to that. And then finally, there is the option of using medication. But first, of course, the question is, should treatment be considered? I think it all comes down to whether or not tics are actually affecting the quality of life, and whether or not there is impairment. Another question is, should we start with behavior therapy of medication? I think the guidelines are quite clear about the importance of starting with behavior therapy over medication. But it's not always working as well what to do next. If then medication is chosen, what agent may be chosen. If one agent doesn't work, what should we do next? And the final question is, when there's not only tics, but there's also these comorbidities. I already briefly mentioned attention deficit hyperactivity disorder, obsessive compulsive disorder, autism. So how does that affect treatment? Like I already briefly mentioned, in many cases, treatments, tics do not have to be treated. So this may be quite obvious, or perhaps quite straightforward, but I think it is good to discuss that the presence of ticks does not necessarily always mean automatically that something needs to be done. But here are a few examples. So sometimes ticks cause pain or injury, or get in the way of getting sleep, or sometimes lead to social isolation or even bullying. But also ticks may lead to heavy interference in things like reading and school. Yeah, so it is always good to discuss, are ticks actually bothersome, and if so, in what area? But these are just a few examples that may justify a treatment approach. It should be remembered that impairment is highly subjective. There may be people with relatively mild tics, but who really suffer a lot from them, and people with quite clear tics who are much more in peace or fine with them. Oh, this is a nice quote of Peter Hollenbeck, a neuroscientist who have tics himself. He says, yeah, it really differs from other neuropsychiatric disorders in one simple way. It's largely the disease of the onlooker. He says, when I tic, I'm usually not the problem. It's often more problematic for the environment. So I already briefly mentioned the concept of psychoeducation. We talked about impairment. It's also good to see, well, is it really the tics that are causing impairment, or is it more the attention deficit disorder or the other comorbid problems? And it's also good to try to objectively monitor the progress of treatment by using some rating scales, such as a good example is the Yale Global Tic Severity Scale, which can be applied in 4 or 5 minutes, and that gives a score to the severity of the tics. We already covered it, that tics are highly variable, but this also affects treatment. So when tics are quite severe, whatever you do, there's a high chance of them getting better, but that is not necessarily a direct cause of the treatment. It's always good to discuss this with your families, and sometimes you may just monitor the tic severity and just watch and wait a little bit about how things develop. So this is a simple thing. People often come to your office when tics are at the most severe, but even if you do not do anything, chances are high that what will be up will also go down. We do have some nice guidelines, and published and recently updated in European Child and Adolescent Psychiatry. And the guideline is really that behavior therapy is the first line, the first thing to try, and only go to medication if behavior therapy is not available. So this is a summary of the treatment recommendation. Start with behavior treatment. It's often a little bit also dependent on the preference of the children, of course, and whether or not good therapists are available. There may be 2 times habit reversal, and there's also a slightly different technique, so-called exposure and response prevention. It's a little bit of detail. And sometimes when tics are really severe, you may also combine them with medication. So this is just a brief overview of the so-called habit reversal. So the whole concept is that many kids actually feel this premonitory urge to have tics, and then you discuss to them to study a so-called alternative response, a competing response that is not compatible with doing actually the tic. So something that is opposite to the tic, the normal tic, but also something that kids are being able to maintain at least for a minute or so, and also, of course, something that is not in itself more worrisome than the original tic. Yeah, there's quite some nice treatment manuals translated in several languages, at least in English, but I think also in German or French. I'm not sure about Ukrainian, but and these can be used to guide the children and the clinician in trying to work with this habit reversal. So they typically treatment often involves 8 to 10 sessions, weekly sessions, and also homework where they study what they have learned and what they have been trained at home. So it's also good to involve the parents in it. So the question then is, does it actually work? Well, not with everybody, but the studies are not so bad. So with improvements of at least 1/3 to sometimes 50%. So I move to the last part of my presentation, and this is about the treatment of tics with medication. It's good to know that actually we do not have really good tic medications. So there is not something that cures tics. So it's only about sometimes suppressing tic symptoms, and it doesn't improve necessarily the long-term prognosis, which is also often favorable without tics. So this may be this is also good to discuss with affected families. So there's really two main medical options. So one is the class of so-called alpha-2 agonists. So I'm not sure what actually is or is not available within the market in because it within Ukraine, because it differs from country to country. But there's two agents that are available in most European countries, clonidine and guanfacine. That's the so-called alpha-2 agonist, and then there's antipsychotics, and so those are drugs that are actually used for psychosis on the market, but also have a place for the treatment of tic disorders. And then the two best studied agents are risperidone and aripiprazole. And this is actually a survey that we did twice, and where you can see that now, or at least in 2019, aripiprazole was the most popular drug within the European context. It has somewhat replaced risperidone. So in a way, aripiprazole is now the most favorable drug for treating tics. Within Europe, most drugs are off-label, including aripiprazole, including risperidone, although aripiprazole does have an approval within the United States. So quickly to clonidine, it's actually a quite old drug. It's actually belonging to the central antidepressive agents. It does take time to reach the effect, weeks to months. It may also have a favorable effect on hyperactivity, but there may also be side effects, mostly related to sedation, depression, drowsiness, and hypotension. And have been really some old studies, 6 placebo-controlled randomized controlled trials, and 4 of them who did show efficacy. This is the largest of them. It's really an old study already, involving 4 groups, a comparison between clonidine and methylphenidate, or in combination, and a placebo. And there it can be seen that after 16 weeks, all groups where clonidine was available did better than placebo. So this is probably the best evidence. Let's move to the antipsychotics. So risperidone, this is one of the first studies that looked at the effects of risperidone compared to placebo. and where it can be seen that after about 4 weeks, risperidone started to do better than placebo. Although the effects are, you could say, modest compared to placebo, but there's reasonable evidence that it does something. And there's also been comparisons to other older type antipsychotics such as pymosine, and so it is reasonably more effective than placebo. So there is some evidence that it may actually work, although metabolic effects, weight gain especially, is one of the most worrying and quite prevalent side effects. So this was one of the trials that led to the market authorization within the US of aripiprazole, and here it can be seen that after already 2 weeks of treatment, it starts to separate from placebo. But you can also see that also placebo isn't doing so bad. So anything you do apparently helps a little bit, but aripiprazole does clearly better. So this was actually a study done in South Korea, and with response rates based on the Clinical Global Impression Scale of Improvement in 2/3 of kids. So this is probably the best we have in terms of medical effectiveness. There's also been some ongoing work. So one trial that failed to have results. So before we end, let me quickly summarize. So a good question is always, is treatment at all needed? Ask yourself and discuss with the family, is it really tics that are impairing, or is it a comorbidity? And if you want to do something about it, please really start with habit reversal. And if medication is being considered, then really aripiprazole or risperidone or clonidine should be the choices, probably in that order. Well, if nothing else works, there's quite a large list of alternative treatments, but these may be used on a case-to-case basis. And I have to say, we not very often use them, and mostly we do well with either behavioral treatment or aripiprazole or risperidone or clonidine. But there are some other options which are all outlined in the European guidelines. I think that's the end of my presentation. It's been hopefully an hour at the end of the day where you could save some attention for this, for which I really would like to thank you very much. And I think there could be time for questions, but I hand over to the moderator. Thank you very much. Perhaps I should stop the share screening, right?
Ви вже його зупинили. Ми на екрані тільки вдвох. Пітер, чи ви мене чуєте?
Excellent.
Добре. В нас є багато питань. Я буду їх задавати, стільки, наскільки в нас вистачить часу. І тоді Пітер буде на них відповідати. По-перше, багато людей питає, чи можна подивитись це в записі. Так, можна. В нас буде традиційно, вже є доступним запис з перекладом на YouTube-каналі доктор Булавінова. І також буде викладений оригінал, англійська версія. І так, переходимо до запитань. Пані Христина Бакум питає, яка схема дозування аріпіпразолу для дорослих при тікі, максимальна доза? І чи можна дітям цей препарат?
Yes, so it's two questions. So children can really take aripiprazole, and I think the maximum dose in adults. Let's. Let's look it up briefly. 1 mg per kg. So 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 1 mg per kg. Uh, and let's look at, because I do not know by heart if there is a um, uh, let me just briefly check it. If there is something like a maximum dose. Yeah, I think uh, in children, um, yeah, we start with a low dose of, let's say, 2 milligram with a maximum of mostly 20 milligrams. But in adults, you could go uh, even up to 30 milligrams per day, depending on, yeah. So the goal is always to start low, but you could go up to 30 milligrams as the absolute maximum.
Пані Віта Дідко питає, чи є у дитини з синдромом Турета психіатричні відхилення? Як можна полегшити життя такій дитині і скільки місяців можна приймати препарат Абізол?
Yeah, so if I understand the first question correctly, whether we should consider Tourette syndrome as a psychiatric disorder, was that the question?
Mm-hmm.
Yeah. Yeah, well, yeah. So I think it is perfectly at the border between neurology and psychiatry. So on one hand, you can say, well, having all those tics, this is typically a movement disorder, but there's also some behavioral part involved. So mostly people agree that it's, I think, part of psychiatry or what they call neuropsychiatry. Um, and when we talk about quality of life, I think on one hand you have the whole issue of trying to offer treatments, but I think it is also what perhaps matters also a lot is trying to have better understanding by the environment, including schools, including other kids, including families, of trying to reduce possible stigma associated with tics. So it's always good to normalize and this type of behavior and see that that people are just diverse and that we embrace or actually accept this diversity. That is perhaps often better than a treatment, and sometimes the benefit of offering behavioral treatments is also that you give the kids a tool that they have more control over their tics in certain situations. So, and I think the last part, and which all those steps may very much enhance quality of life, more acceptance, less stigma, better understanding, also at school, and giving them tools. And if you want to turn to medication, which we only do in minority of cases, then it's always good to try if after a couple of months, after 5 or 6 months, the medication may also be reduced. But there's no hard rules for the length of medical treatment. But yeah. I think that
Пані Ірина Хмелєвська питає, який саме вид психотерапії показаний дітям з тикозним розладом?
It depends how we define psychotherapy. I think in the classical way, what is often meant with psychotherapy is probably not needed. But I briefly talked about habit reversal as a behavioral treatment. We may group that as part of the psychosocial treatment or psychotherapy if you wish, but I think there's no no direct place for psychotherapy in the strict sense with the kid.
Так. Юлія Машкова питає, якщо у дитини тики проявляються у частому морганні очима, то у випадку застосування поведінкової терапії, що може бути запропоновано батькам?
Yeah, well, the classical thing is to try and find something that is incompatible with blinking, so which could mean open the eyes, so force yourself to open them deliberately, and you don't have to do that for hours, but when you feel the urge of this eye blinking, and often kids will find out that when they just do something which is incompatible, and they just do it for a minute or so, then the urge is also disappearing, so they get more control over their tic. So that's a little bit the basic concept of it.
Пані Дар'я Кияненко питає, які медикаменти можуть бути застосовані в першу чергу, якщо у пацієнта є і синдром Турета, і ОКР з переважанням компульсій?
Yeah, I see. Well, of course, it depends what is most prevalent, or what is most concerning. But there is some indication that when there is obsessive compulsion disorder in the presence of tics, that then antipsychotics may be more effective than, for example, SSRIs. And sometimes they may also be used in combination. So I think when there's also tics, I would probably prioritize, assuming no behavioral treatments is indicated or that has failed, then I would probably think that at least having also antipsychotics there, either alone or in combination with antidepressants, with SSRIs, would be a wise approach.
Пані Ольга Слободяник питає, чи може бути психогенний фактор у появі тику?
I see whether that can be a psychological trigger. Is that what? Yeah, with psychogenic. I think it is probably psychological factors in themselves are hardly sufficient as a trigger, but there's two things that is good to know. That tics often may have their onset in times of higher levels of stress or kids being excited. Some kids are really being excited, younger kids, about the Christmas celebration or about around their own birthday, when they may get some presents and they can really be excited about it, or when something stressful, and that is often the time that there may be tic onset. There's also, and I think we saw that especially during the COVID pandemic, there's also people, and especially adolescent girls, who show so-called functional tics. So they often show quite clear and exaggerated and severe tics, but who people think these are not really part of Tourette syndrome, but are part of so-called psychogenic tics, and that may be triggered also by social media, especially TikTok clips, where having Tourette's may be some of the strangely not more popular things, and people try to copy them, and this is so-called functional tic disorders, which is quite well recognized, and over the past years, but people think that is separate from classical Tourette syndrome.
Пані Ірина Хмілєвська питає, що передбачає програма Comprehensive Behavioral Intervention for Tics, CBIT, і чи потрібне спеціалізоване навчання для опанування цієї методики?
Yes. So most people agree that some kind of specialized training is really helpful and actually is also offered. We have a so-called European Society of Tourette Syndrome. So it's a group of European specialists with a clinical or research interest in tic disorders, and always as part of this, there are free trainings that are being offered for clinicians that would like to be trained in the behavioral treatment. So the next, it's always in June, and the next conference is actually in Slovenia, in Ljubljana. So yeah, so for those clinicians who have the possibility or the interest to go, that would be highly recommended.
Пані Лола питає, як можна профілактувати появу тиків?
In a kid, I think we do not have a way to prevent the onset of tics, not that I'm aware of. So, yeah.
Пані Ліана Шимоняк питає, чи є статистичні дані успішності використання поведінкової терапії?
Yes, mostly there is a reduction of between 35 and 40% of tics. That is what is to be expected. And of course it depends. It also depends on the motivation of the kid, because it needs some work to be done. It also depends on the support of the parents, but if the environment is right, the motivation is there, then it can really bring about meaningful reduction that are as at least in the same range as what medication typically may achieve.
Пані Олена Ковальчук питає, чи є доречним використання нейролептиків у дітей при тикозних проявах?
Yeah. I think neuroleptics is just another word for antipsychotics. I highlighted two of the most useful antipsychotics, aripiprazole and risperidone, but there's also been other studies, older studies that also showed the efficacy of older antipsychotics, or if you wish, neuroleptics, including haloperidol and pymoside. So these may have more side effects, but they are still acceptable choices that have been used for many decades. Yeah.
Пані Лола питає, який генетичний тест може виявити схильність до появи тикозних розладів?
Yeah, that's a good question. Unfortunately, we currently have no such test that can be used in the clinics. So the point is that we can only identify a really small proportion of the genetic risk, and currently there is no genetic testing available that's of any use just for an individual patient. So it's solely a research tool.
Так. Пані Олена Утюгова питає, чи можлива поява тиків у дитини через психічне та фізичне насильство у сім'ї?
So the question is whether a physical or or other types of violence within the family may cause tics. Yeah, I'm not aware. You could say, well, having violence in the family is obviously a major stress factor for the child. So in this sense, it may also be a risk factor for things like tics, but it's not a well-known causative factor for tics. Although it's a reasonable question, you could say, well, when a child is growing up in an unstable, violent family environment, and then you see tics, it may be a reasonable question, but it's not a known risk factor, not that I'm aware of.
Пані Олена Ковальчук питає, з якого віку у дітей можна використовувати антипсихотики?
Yeah, it's a good question. I think there is no no lower age, so there is no strict age range. So whenever a child has quite severe tics that do not go away, otherwise you may already start them at the age of 5 or even 6. So there is no strict lower age limit for starting them. Although I am arguing for the cautious use of antipsychotic medicines, but whenever there's a good reason, then there's not really a lower age limit.
Пані Ірина Хмілєвська питає, сульпірид можливий для стосування при такозних розладах у дітей?
Yes, certainly. Yeah, that is one of the antipsychotics, and I think it is not available in every country, not where I live, but it's been in good use, at least in the UK, and also a quite similar medication called thiaprid has a good use, especially within the German-speaking part of Europe, Germany, Austria. Yeah, so it depends a little bit on the region, but there's been regions where also sulpiride has a good use base, and also not many studies, but there's no reason to believe why that would not work.
Пані Лола питає, чи голковколювання є помічним при тиках?
I think there's, especially in Chinese medicine, there's quite a tradition of also using acupuncture. I have to say, I'm not familiar with that type of treatment, and also we never used it, and also do not know what the effects are there, but there are certainly studies out there. Yeah.
Ксенія Лаптєва питає, чи є ефективність застосування нормотиміків при лікуванні тику?
Normatinics, what...
Напишіть тоді, пані Ксенія, що ви маєте на увазі під нормотиміками. Угу. Зараз, секундочку. Якщо, пані Оксана Жибак питає, якщо у дитини тики протягом 5 років, які проявляються 1-2 рази на рік, тривалість пару місяців, чи може з часом тикозний розлад перейти в синдром Турета?
Yes. Yeah. So that is certainly possible. It's hard to predict. So I already mentioned that many tics are temporary. Tics may come and go. Sometimes they disappear completely, but they may also. So it's hard to predict how it will eventually evolve, but that's certainly possible. Yes.
Угу. Пані Марина Теплих питає, тики у дорослому віці, якої потребують схеми лікування? Тик проявляється у пересмикуванні плечима та судомах обличчя.
I think one of the good points is one of the advantages of adults compared to children, that adults are often better able to describe what tics, how they bother, how they impact the quality of life, how they impact the functioning in daily life. So that's actually an advantage. I think it should be shared decision. It should be discussed with the adult, and the possibilities and the possible downsides of medication should be discussed, and then it is highly dependent on the preference of the adult with such tics.
Пані Філіпчук Олена питає, чи доцільно використовувати галоперидол при важкій формі Турета?
Yes, I think it's a good choice. Haloperidol, it's an old drug, but it is actually one of the drugs that is officially indicated for treating tics, and there's actually a relatively good evidence base for it. So the answer is yes.
Настя Рокутова питає, чи може ноофен посилити тики?
What is NOASM? It is an
Ноофен. Це назва препарату.
Is it something against coughing or no?
Зараз я подивлюсь швиденько, що малось на увазі. Так, ноофен.
Yeah, I don't think there's any indication that may trigger or exacerbate tics. So it's an antihistamine agent, right? Yeah.
Угу. Так. Там, де було питання про ліки, то тут два є пояснення від наших спікерів, від наших глядачів. Пані Ксенія Лаптєва таке пояснення дала. Стабілізатори настрою, вальпроати, карбамазепіни, ламотриджини.
Lamotrigine, so the anti-epileptic that can also be used as mood stimulators, right?
Так. Right.
Yeah, I don't think they have a place in the treatment of Tourette's.
Так, одну секундочку. Пані Анна питає, які є рекомендації при коморбідності з рдух, адже препарати, що використовуються при рдух, збільшують тики?
Yeah, I think that's an excellent question, because the number one treatment of tics is are stimulants. Methylphenidate is the most widely used agent, and I think actually one of the warnings is that one of the possible adverse effects may be tics in susceptible persons. So there often has been reluctance or cautious use of methylphenidate in case of tics, and it also looks like you do a little bit the opposite thing than the antipsychotics, but still there have been quite some studies, and now the guidance is that they may be safely used and only very occasionally may trigger tics, but in a majority of cases not. And if they do trigger tics, then you can stop them, and then this effect will also be gone away. So I think the bottom line is they can be safely used. There's no reason not to use them.
Пані Катерина Шикаряк питає, чи є потреба здавати аналіз на стрептококи при появі ОКР в 14 років.
No, I don't think so. No, because it doesn't say really anything. It may be positive, but that doesn't say it may be a coincidence and it doesn't involve treatment. So I think that is not necessary.
Пані Алла Ягушева питає, бензодіапіни призначаються при тиках?
I think there's no evidence base for doing that. Of course, you can say, well, some of the kids with Tourette's may be anxious, so you give something to relax. But then with benzodiazepines, there's also the risk of addiction, and there's really there's really no evidence based to use them as a treatment of tics.
Пані Ірина питає, Когнум 500 плюс Ізірел – це є лікуванням синдрому Туретта та тиків?
Which agent? Something with Israel? I'm not sure I understood.
Зараз ще раз скажу, як це називалось. Когнум 500 плюс Ізірел. Це є лікуванням синдрому Туретта та тиків? Ізірел.
I'm not sure if perhaps you should look it up. Cochrane 500. Yeah. Yeah, I think we should look that up. What that?
Добре. Пані Віта Дідко питає, чи
Okay,
пов'язані-
yeah, I see. I'm not familiar with that. Unfortunately, so I can't. I have no experience with that, but I think the evidence of plant-based components is limited at best. But I have no experience with them.
Пані Віта Дідко питає, чи пов'язаний між собою синдром Туретта та розлади сну? Дитина спить вдень, а вночі ні.
Yeah, that's not good for the child, because it should during the day be at school, and but it is a well-known problem that children with Tourette syndrome often have difficulty falling asleep and delaying their sleep, and then sleep in the morning when they should get up. That is a well-known problem, and it's. I think we mostly try and find behavioral treatments for addressing those sleep problems, but it is it can be a big problem, yes.
І останнє питання з нашого сьогоднішнього вебінару від пані Лялі Ситнік. Хлопчик 12 років, діагностовано рдух ще з раннього дитячого віку. Є порушення мовлення у формі запинання в мові. Є періоди, коли ці запинання появляються часто впродовж дня, а інколи декілька днів відсутні. Запинання в мові проявляються на початку слова, наче не вистачає повітря. Виглядає так, наче задихається. Який метод психотерапії обрати для корекції стану? Та чи можливо повністю прибрати ці стани?
Yeah, well, this is an excellent question. There is really an association between stuttering and Tourette syndrome. Not every kid with Tourette's is stuttering, also not the other way around, but there's a clear association. And sometimes even there have been studies of studying the effects of clonidine, also for the sake of stuttering. I have to say, I am myself not an expert in speech therapies or what to offer, so I unfortunately cannot specifically give a recommendation for that, but I can affirm that there is a known association between stuttering on one hand and Tourette syndrome at the other hand.
Угу. Ну і тоді останнє. Тетяна Грицькова питає, фенібут у дітей лікує тільки чи ні?
Phenibut, yeah? I'm not sure I know that name. What kind of drug is it?
Зараз перевіримо. Фенібут. Це психостимулятор, ноотроп. Мені якийсь такий препарат.
Psychostimulant drug. I see. I'm not aware of any studies that looked into the effects of that compound for studying Tourette syndrome. So I don't think there's any evidence base for using that.
І перед тим, як ми закінчимо, я ще раз хочу представити нашого спікера. У вас було дуже багато, до речі, людей, навіть було 400 плюс людей на Zoom, і дуже багато людей лишались на питання та відповіді. Да, і дуже вам дякую. Більше ніж 300 людей лишалось на питаннях та відповідях з нами. Тому хочу ще раз вам представити всім, хто до кінця з нами був, ще раз представити нашого спікера. Це Пітер Hoekstra, дитячий та підлітковий психіатр спеціалізованій амбулаторії Accare в Гронінгені, де працює з стиковими розладами та РДУХ, досліджує ефективність фармакологічних і психосоціальних втручань при РДУХ та супутніх розладах, а також вивчає етіологію синдрому Туретта і РДУХ з використанням нейровізуалізації, нейрокогнітивних методів та епідеміологічних підходів, включно з аналізом ролі генетики та взаємодії ген плюс середовище. Ми дуже дякуємо нашому спікеру, дуже дякуємо професору Йоргу Фейгерту, який нам допоміг і допомагає організовувати всю цю програму навчальну для вас. І також дуже дякуємо пані Оксані Збітнєвій, голові Координаційного центру з психічного здоров'я Кабінету міністрів України, Міністерства охорони здоров'я та НСЗУ за партнерство в цьому проєкті. Ще раз дуже вам дякуємо, Пітер, за таку змістовну лекцію і за відповіді на питання. Особливо, що ми розуміємо, що це вечір і що ви могли би робити щось інше в цей час, але ви навчаєте нас, і ми вам дуже-дуже вдячні за те, що ви свій вільний час присвячуєте українським лікарям. Всім дуже дякуємо, хто нас дивився, і бажаємо, наскільки це буде можливо, тихої ночі на сьогодні. Дякую ще раз, Пітер.
Yeah, it's been my honor and pleasure, and I wish all good luck for Ukraine for the future. Thank you.
Всім дякуємо.